Hi everybody, this is Dr. A and this is the first lesson in the medical microbiology series, and we're going to talk about specimen management. Okay, so in the microbiology lab, we generally grow bacteria. There would be cultivation and maybe some yeast or fungi. And then we proceed with all the testing to identify the cultures that have grown on the petri dishes or the plates. And we do antimicrobial susceptibility testing so that we can make sure that the patient is receiving the correct antimicrobial antibiotic or even antifungal. There are several ways we can identify bacteria in the microbiology lab. So we can do direct detection. So this could be through microscopy, for example, where you would do, for example, a gram stain, and you can get some preliminary ID. There are also a few things that are diagnostics, like if you saw some gram-negative diplococci inside of some white cells on a penile or vaginal smear, then that would probably be diagnostic of gonorrhea. So other detection methods can be used that are also some direct detection. So immunologic is pretty common with these, like lateral flow immunoassays. So for example, this one for C. difficile, we look for the presence of the antigen and the toxin. These can be used also a lot for viruses. You would be definitely familiar with the COVID test, the antigen test, the flu test, the RSV test. All of those are types of lateral flow immunoassay, even the strep test. So those are some of the direct detection methods. We also can do some chemical tests. So there are some little tests like we're going to talk about, like the catalase and coagulase and different things like that. And then we can do molecular panels, like the BioFire film array panel is just one example, but they have some really cool panels that are molecular. There are also, of course, molecular ways to detect viral infections, etc. And then serologic detection, it's more about detecting the antibodies to certain infections that may not be able to grow very easily, and maybe we don't have any lateral flow immunoassay available. So think of your tick-borne diseases and certain viral diseases like HIV, where the initial screening might be to look for example, the anti-HIV antibody. All right. With microbiology, like any other aspect in the lab, it all starts with a good specimen. So you need a good specimen collection and handling. And so the specimens are often collected by our nursing staff or maybe our respiratory staff, and so sometimes the lab may have to do some in-service system training if there are problems with collection techniques. Typically, specimens are collected during the acute phase of illness, so when they present, when they're sick, when they're having signs and symptoms. The collection should be performed so that it minimizes the contamination by normal microbiota. So for example, if you were to swab a wound, you would want to just only go into the pussy area of the wound and not get the skin on the outside of the wound where you would pick up some normal skin flora. If you need a sputum culture, it needs to be something that's coming from the lungs, right, from the bronchi and stuff, that some of the yellow or green mucousy junk is coming up. You don't want them to just spit in a cup, give you some spits from their mouth. That's not what you're after, right? And so there should be some standard operating procedures written up for the nursing staff or for any clinician that may be collecting specimens. And if the patient has to collect a specimen, you have to give them very clear instructions on how to collect the specimen. The example would be the instructions you would give to get a clean catch urine specimen. And the collection generally of the specimens, we ideally want them to be completed prior to any kind of antimicrobial, antifungal, antibiotics, antiviral, like any of those things. Because of course, as soon as you start administering those and start treating the infection, you could reduce the likeliness of catching the microorganisms so you can properly identify them. And all that, sometimes there are some protocols. For example, for a patient that comes in with pneumonia in the emergency room, you need to collect blood cultures before they start the antibiotics. So sometimes they'll call for some stat blood cultures, and it's not because they are in a hurry for the bacteria to grow. They're just in a hurry for you to collect them before they start the antibiotics. And then there are also some protocols where their antibiotics need to be started within, usually it's 4 hours of them presenting to the ER. And if you factor in the time of triage and assessment and testing, that 4-hour window closes really quickly. And by the time they know that this patient has pneumonia and needs blood cultures and needs antibiotics or antimicrobials started, like that window to get those blood cultures could be kind of closing. So specimens should be transported to the lab within 2 hours. That is ideal. So really right away, you don't want to set them down because then you might forget about them, and you definitely don't want them sitting in a nursing station for an entire shift or a day, because then the specimen is no good. This is especially important for specimens that are difficult to collect, like pericardial fluid or pleural fluid or spinal fluid, and surgical specimens and things like that. The container for the specimen should always be a leak-proof biohazard bag. This is especially important for liquid specimens. Make sure the cap's on there tight. There are some pretty neat systems that have been put out where for liquid specimens like urine, once the specimen is in the urine and the lid is shut tight, you don't have to open it again, and you can access it through this collection port, and it's sterile and it's pretty cool. Sometimes the specimen may have to be preserved. For urine, we can use boric acid, and so if delays, the testing is going to be delayed, and it needs to be sent maybe to a reference lab or something like that. For feces or stool, the polyvinyl alcohol buffered formalin is used. These look like this right here. And so sometimes that's something that the lab might have to do, where the nursing staff or the patient is bringing looks like a Tupperware bowl, right, with poop in it, and then it needs to be scooped and transferred into these vials. The vials come with a scoop attached to the lid where you can fill it up to the line so that you have an adequate amount of specimen. And then sometimes some of the swab cultures might be put in some holding media, and Stewart's and Amy's media are commonly used, and it will be written on the label here what type of media is in there. This can help prevent the specimen from drying out. And sometimes anticoagulants might be needed, for example, for blood or bone marrow or synovial fluid. So some of the common ones utilized are the sodium polyethanol sulfonates, or SPS tube, this one right here, heparin, which is our green top, EDTA, which is our purple top, and citrate citric acid dextrose, ACD, which is this other yellow. So be careful to not confuse these two. They're not the same, and to really check your specimen requirements if you're collecting these for a send out of some sort. And yes, these tubes are sterile unless you open them, and of course once you open them they're not, but the inside of the tubes is sterile. Specimen storage. So specimens are stored if they are not processed immediately. There are several storage methods. Refrigeration is the most common at 4 degrees Celsius, but sometimes there are some specimens that cannot be refrigerated because it would kill the microorganisms, or it's not good for this specimen. For example, spinal fluid should not be put in the refrigerator, so it should be ambient temperature, 22 Celsius. Some of them might need to be kept at body temperature or need to be frozen really quickly at -20 or -70 Celsius. So specimen labeling, so important. So your specimen label should contain information that matches the requisition. It used to be all handwritten. Now, of course, it's heavily barcoded, so that's really cool. So usually you have some printed barcodes with the information about the requisition, the type of specimen, etc., and the test needed. You just want to make sure that the sheet of barcode stickers that is with the specimen matches, right? That they didn't get anything crisscrossed or confused with a different patient. And also pay clear attention to the type of specimen it is. So there are lots of different swabs that can come in, and it could be a wound or strep or a flu or something like that. And there are different types of yellow liquids. So, I mean, it could be urine, that would be the most common, but maybe it's peritoneal fluid. So pay close attention to the type of specimen. Some of the information that is needed to properly identify a specimen are the patient's name, the hospital identification number, so that could be the medical record number of the patient, or it could be the specimen accession number, right? The patient's age and date of birth, which the name and date of birth are the two primary ways we identify patients. Sex, male, female, the collection date and time of the specimen. So that is really important, often overlooked. So we need to know when the specimen was collected, and ideally by whom. So it's not as if they put their initials, like collected, date, time, and put their initials on the specimen or on the requisition, who the ordering physician was, and especially also very important, the specimen source. Again, there are a lot of swabs. You know, once you get a swab, I mean, it could come from anywhere in the body, right? And so it's really important to note that. And then even, let's say, if it's a wound swab, a patient could have several wounds. We need to know where it's from and which wound it's coming from. And then this is, I've not seen really put on the barcoded requisition as much, but the information is available, is their diagnosis and current or previous antimicrobial therapy. So oftentimes that can be accessed through the electronic health record of the patient, and so you should be able to look that up pretty easily. So what could cause rejection of a specimen in the microlab? And if you're working in central processing or in microbiology, then it's your job to look for this and to reject specimens that aren't meeting your criteria. So if the specimen is mislabeled, so there's a mismatch between the requisition and the label on the specimen, or they put, sometimes they use nursing chart labels, and then they put the barcode label from the requisition from the lab, and maybe if those don't match up, right? If the specimen was improperly transported, so it's at the incorrect temperature, it should be refrigerated and it's not, or should be not refrigerated and it is. It has been put in the incorrect medium for transport. It's either missing or it's the wrong one. The transport time is exceeding 2 hours, or if it is exceeding 2 hours, it's not preserved, not put in the proper way to stop bacterial growth. And again, the transport time exceeding 12 hours can happen easily when people get distracted and time kind of gets away from them, and they forget that that specimen still hasn't been brought down. There's not enough of specimen to do anything with. Now, for some things it doesn't take that much, but there are some tests where it does require more. Sometimes one of the issues there would be, like if you were trying to do one of those parasite containers where you scoop in and you put stuff in there. Like if somebody's bringing you some baby diapers and it's diarrhea and it's kind of all soaked into the diaper, it can be sometimes difficult to get enough specimen. If the specimen is leaking, because then of course it's contaminated. If the specimen is in a fixative, and that varies based on the specimen type and what's required. If it's an anaerobic culture and it's requested on a sample that is known to have anaerobes as normal microbiota, like a stool, for example, or if the specimen is all dried up, because then likely the bacteria are all dried and they're not going to grow. So then when it's processing into the lab, so again, this is what central processing does a lot. We need the receive time and date that is documented on arrival. So that's it being processed into central processing as it arrives into the lab. And this is very important because often lab management, risk management, etc., needs to be able to track the flow of a specimen from the time, from when it was ordered to when it was collected to when it was received in the lab to when it was resulted, and this is for any specimen in the lab. So we would give priority to the most critical specimens. So things like the spinal fluid, that's definitely a high priority. And you do a quick gross examination. So we look at the sample, make sure there's enough, it's not leaking, etc. And, looks like it's an adequate specimen for the orders. And you always want to make sure that, for example, if it's a swab, or you want to use the part that's bloody mucousy, gross looking, to use that to swab on the culture plates to inoculate them. Sometimes a specimen might need to be prepared, so they might need some further things. So homogenation, for example, if it's a surgical specimen of bone, a biopsy of bone is something that needs to be cultured. It needs to be ground up, mincing or cut up for tissue. Some liquid specimens might need to be concentrated via centrifugation or filtration. This is what's shown here, where the organisms are caught on the filter paper, and then that's what's on the agar. Sometimes decontamination, sometimes you need to break up some of the mucus and normal flora, for example, in respiratory specimen. And then we can often do in the lab a direct microscopic examination straight from the swab, straight from the sputum, from the sample that was sent, from the specimen that was sent. And that helps us see if it was a good quality specimen. It can give you some preliminary results of the morphotype, meaning, there's some gram-positive cocci in there, or there's some gram-negative rods, or we see some gram-negative diplococci, or something like that. And then, if we see pus cells, etc., and again, that indicates it's a good specimen, that it was collected from the right area. And in there, we might also be able to identify some pathogens that are not easily cultivated, so certain parasites or things like that, right? And there are several differential staining techniques, like the gram stain and the acid-fast stain. We have also periodic acid shift, chalcofluor white, and a GMS stain. So the Broccott's methenamine silver stain. Now, those last three, so the periodic acid shift, chalcofluor white, and GMS are usually used for fungal stains, fungal yeast stains. The KOH prep is a wet mount, usually done to look for hyphae and for yeast, often done on vaginal swabs and stuff, looking for yeast infections. And that one is the only one that's not technically a stain. So the morphotype stud you can identify, so you need to be able to look at the, their morphology. So are there cocci, diplococci, streptococci, sarcenia, a staph, which is coccine cluster. Do we have a cocobacillus, a bacillus, streptobacilli, etc.? And then note, of course, usually their gram stain reaction as gram positive or gram negative. So we do the gram stain, that's the primary stain staining method that we use in micro. Gram negatives are pink, gram positives are purple. The PAS stain, again, a fungal stain, where you can see the fungal elements here are in pinkish red color. The background is in a green color. KOH prep is, then you can see it's a wet mount, no stain, but you can visualize hyphae and maybe some little yeast or pseudohyphae or different things like that. The acid-fast stain, this is used for TB, Mycobacterium TB identification. The acid-fast bacteria are the pinkish purple color, whereas the background is either going to be blue or green, depending on the counter stain used. Chalcofluor white is a fluorescent stain that helps visualize fungal structures, especially in tissue specimens. And Broccott's Ogomori's methenamine silver stain, it stains the yeast forms here in that dark gray color with the background in green. Culture media are used to grow these bacteria, but also some yeast and fungi. Nutritive media supports the growth of a wide range of microorganisms, and so it's often used. It includes blood and chocolate agar. So we set up a lot of blood and chocolate agar in the lab because a lot of things will grow on it, so we can detect as much as possible in a specimen. A differential media helps to differentiate organisms based on specific characteristics. So it usually is like if you can turn a media a certain color, or if the colonies change color if they're growing on that media, it can help us identify what is growing. They are selective if it supports the growth of one group of organisms. So, for example, your McConkey is selective and differential because it allows the gram-negatives to grow but not the gram-positives, and then your lactose fermenting organisms will turn pink on that plate. Oftentimes a backup broth is set up on many cultures, especially wound cultures. It's usually a supplemental or enrichment broth. It is used in conjunction with solid media, and that's in case there are some problems you need to go back and sub it out or reculture some things. The backup broth is excellent for that. So here's the blood agar plate, in which you can also visualize hemolysis, which is really cool. So your differential and selective, for example, here's your McConkey. So it would grow E. coli and Proteus and Salmonella, but not Staph. And then if they're lactose fermenting, they turn pretty pink here. So your plates should be inoculated. Usually we use the quadrant streaking for isolation method, where you put your inoculum in section 1, and then you're going to use the sterile loops, do each following quadrant. And in quadrant 2 here, you're going to make sure that your loop goes into the inoculum in quadrant 1 several times, and then you're pulling it out. You want to make sure you have plenty of little streaks going, and then quadrant 3 goes into quadrant 2, and quadrant 4 goes into quadrant 3, and you can even do a 5th one if you want to, like if you have room to spread it out. The idea is you're trying to thin and thin and thin out the colonies so that you can have separated, isolated colonies. So this is very commonly set up. And there is also another one we can use, kind of so semi-quantitative really. So it's a quantitative loop of like 10 microliter like this, used in urine. And it's more for like what we call a colony count. So you would go down the middle once and then take the loop and go zigzag, 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 zigzag. And then with a 10 microliter loop, like each colony is 1,000 microorganisms. And so if you have 10 colonies or more, 10,000 or more, it starts to become significant. You need to have at least 100 colonies or 100,000 microorganisms to really, for any urine to be considered like this is a UTI. If you have 10,000 or less, so that means 10 colonies or less, then it's probably just skin flora or contamination. We need to incubate the plates in the proper conditions. So aerobes love ambient air, 21% oxygen and 0.03% carbon dioxide. Your anaerobes cannot grow in the presence of oxygen, and so they need 5 to 10% hydrogen, 5 to 10% CO2, 80 to 90% nitrogen, and no oxygen in there. And so we usually typically have these anaerobe pouches. You may have anaerobe systems, larger canisters where you can put the anaerobe stuff to to change, to remove the oxygen and create an anaerobic environment for the plates. Where I used to work, we didn't set up a ton of plates, so we used the zipper pouches and stuff, and it worked really well. For your microaerophilic, the capnophiles require increased CO2 and 15% of O2, so it's a little bit less than the 21%, right? And the microaerophilic need reduced O2, so 5 to 10% of O2, and increased CO2 at 8 to 10%. So those conditions, again, can be created in contained environments and then put into a regular incubator. So most medically relevant bacteria are facultative anaerobes, meaning that they can operate anaerobically, but they aren't really bothered by oxygen that can detoxify. The temperature required, most medically relevant organisms are going to grow at body temperature, so 35 to 37 degrees Celsius, and fungi like a nice warm room, so 28 to 30 degrees Celsius, which is, a nice warm room temperature. And then we do a specimen workup and attempt to identify the organisms. So sometimes we can only do limited identification, and sometimes we can do complete identification. So if there are biochemical panel tests that we can do, for example, your gram-positive cocci, we can do complete identification because we have the biochemical panels for that. But if you're growing a gram-positive rods, it might be more limited in your identification. We can do presumptive identification with some of the initial testing. So if we have a wound and we see some gram-positive cocci in clusters and they're catalase positive and coagulase positive, we can presume it's Staph aureus, so we can, get that presumptive identification until we get further testing done. Definitive identification will also include antimicrobial susceptibility testing, because we also know that that's part of identifying the bacteria to see what antimicrobial components they are susceptible to. And we do an antibiogram. It is also, of course, the other idea is to know what antibiotics would work to treat that infection is the other one. And then, we do the biochemical test as part of that panel too. Although you can do it with biochemical test and antimicrobial susceptibility in one panel, or sometimes it's in two panels. So it just kind of depends on the systems that you're using. We have to be able to differentiate normal microbiota versus a pathogen, because there are some places where there are normal microbiota and you expect to see it. And then also be aware of any critical or panic values. For example, any organism in the blood culture is a critical panic value. Any organisms in the spinal fluid. If you see malaria on a blood smear or babesia, a positive acid vastane, it has to be called. And then select agents that could be, especially like bioterrorism agents, need to be called, like Yersinia pestis, right? And then any anaerobes like Clostridium perfringens are, called critical or panic values. And that is a wrap up for your first lesson. Thank you.